think I'll start with ctDNA, because ctDNA is something people are using, and maybe you guys on this side can comment on your use of ctDNA. How is it incorporated into your practice, and what things can we learn about it from this study? Dr. Brown.
I'm beginning to use ctDNA more. I like to get it at baseline and then at completion of neoadjuvant therapy, because we know
in gastric cancer.
Yeah.
So baseline, you mean when you make a diagnosis?
Yep.
And then before surgery.
Before surgery. So there was the Plagas study that was published in Nature Communications, I believe, last year. It showed that it provides some prognostic information. Those patients who clear their ctDNA do better if they clear it during neoadjuvant therapy. And in the postoperative space, if they're ctDNA negative, they also they have better prognosis as well. Not quite as good as those who clear during neoadjuvant therapy. So I think it very clearly has some prognostic role. The issue is I don't know that it's actionable quite yet. And that's the one hang up, and that's the one thing that I very carefully counsel patients on, is that we might get a result here and we may not know what to do with it. Are you okay with this?
So you're when you're having that, so you're drawing it and having that discussion with your patients.
Yes.
I think I treat colorectal too, so I use a lot for colorectal, but I think upper GI cancers are different. It's not more.
And when you say a lot, sorry to interrupt, are you using tumor-informed, using the mostly Nataliya's assay?
I use different ones, including Nataliya, and I would use
tumor-informed assay.
Yes, and so I would check the after surgery as a surveillance method. But I think upper GI cancers are not the same shedders, and so I think it'd be interesting to look at how it was incorporated if data comes out, but I feel I might use it, but it does, as you mentioned, it doesn't change my practice. Some patients it causes apprehension too. So depending on the patient acknowledging, it really doesn't have clear implications.
Do you use it?
In upper GI, not as much, because I feel like it adds a lot of anxiety that I have to be the therapist of. So I don't use it so much in upper GI.
What about you?
I use it.
You do? How do you use it?
I use it the same way that Brown's speaking about, using it at baseline, and then I get it post-operatively, take a look at it. I think it gives us a good
What do you do when your patient's ctDNA positive?
Well, they're still, for the most part, still going to get adjuvant therapy, and we're going to keep going
So you keep going with the adjuvant therapy. Sunnie, you use it?
I use it in a path CR setting
So
because
a total path CR.
Yeah, if a patient is a path CR and we're having that discussion that your prognosis is great, but I am talking to them about doing FLOT for 4 more doses, doing a year of Durvalumab. We have that conversation about if it's negative, do we want to perhaps cut the Durvalumab short? And I like to do a lot of serial ctDNAs too. I'm not going to take one value and take that as face value. Yeah, but that is very much a case-by-case basis. But looking forward to looking at the ctDNA analysis from
I mean, it's all been collected, right? So it's been collected at baseline at, I don't remember what the time points were, but certainly at surgery and then serially over time. And I think the important, really fairly binary question is clearance, right? That's the most, I think the most relevant thing is not did it decrease so much, but did it go to zero?
And we were just talking about that year of Durvalumab causing immune-related toxicities. Right. Do I want to put my patient through that if the ctDNA is consistently negative?
So and if you can feel good that ctDNA negative correlated with long-term survivor outcomes,
even better, yeah.
You would feel much better. But yeah, I know, I agree. I think we need to put that data out there. That's a big plug there.